Hello there, this is Dr. Mintz. This is a 19-year-old male with abdominal pain and nausea. I'll give you a chance to just look over the case and get an idea of where you think the abnormalities might be. I think this is a reasonable approach to reviewing cases in general, to kind of give it an overlook, just to give yourself a heads up about where the obvious abnormalities are. And once you've done that, it's important to go through a systematic approach to the structures. And to me, the easiest way to do that is liver, spleen, and pancreas. So I go through the liver, and then on the upward sweep or a couple sweeps through the spleen, I evaluate the spleen. Pancreas doesn't jump out as clearly as the liver or spleen in many cases like this, especially with the rather pronounced paucity of fat in this individual. You can see even the subcutaneous fat is minimal, and the retroperitoneal fat is minimal as well, so that tends to obscure the anatomy of the retroperitoneal structures and mesenteric structures. So here you can see the pancreatic head, and as we go superiorly from that, we come into the pancreatic neck and body, and the pancreatic tail, which extends and points toward the splenic hilum. The splenic vein has a pretty constant relationship to the pancreas, being posterior to the pancreas along its entire length. The splenic artery tends to become more tortuous with age, and therefore has less of a consistent relationship anatomically to the pancreas. We can see the gallbladder here. There's the gallbladder. No obvious abnormalities there. The adrenal glands are superior anteromedial to the kidneys. In other words, they're superior, a little bit anterior, and a little bit medial, but it varies from person to person. These adrenal glands are not very clear because there's such a paucity of retroperitoneal fat, but these little lines here, right here, are the adrenal gland on the right, and then on the left, this one has a little bit more substance to it right here. That's the left adrenal gland. They typically stand out quite a bit more because there's more fat separating the adrenal glands from the adjacent structures. Here we can see the abdominal aorta, and these are the crura of the diaphragm. The right crus and left crus of the diaphragm comprise the crura of the diaphragm, crura being plural for crus. As we follow the aorta inferiorly, the first vessel emanating anteriorly is the celiac artery. Immediately inferior to that is a superior mesenteric artery, which dives anteriorly a short distance and then continues inferiorly within the substance of the mesentery. Here it is here. Here it is right there. And then, of course, it's branching as we go farther and farther downward, branching in the substance of the mesentery to send off branches to the bowel, which is at the margin of that mesentery. Okay, so now let's take a look at the abnormalities. So basically we have an amorphous area of edema with probably some fluid collections in the right lower quadrant. It's a little difficult to identify what anatomy exactly is involved. Bowel anatomy can be difficult to identify with certainty when it's very abnormal, as in this case. But we can take a look at another another orientation. And here we have coronal images. And I'll let you just kind of look through those overall here, get an overview here. You can see there are a number of enlarged lymph nodes in the mesentery, particularly in the right lower quadrant. We have a fluid-filled structure here and another right here. Unclear if that is dilated fluid-filled bowel or an extraluminal collection. It's certainly possible it's an extraluminal collection because here, at the location where I would expect the terminal ileum to come in, there is a prominence just about where I would expect to see the terminal ileum joining at the ileocecal valve, and I suspect that's what we have here, that this is all edematous terminal ileum and ileocecal valve, suggesting inflammatory bowel disease. Most likely this would be Crohn's disease. Ulcerative colitis appears less likely. These fluid collections here, I cannot identify for certain whether they are part of bowel or whether they are extraluminal collections, but I suspect that they are extraluminal collections. I suspect that what we have here is a pronounced inflammatory process in the terminal ileum, typical of Crohn's disease, a little bit more pronounced than I would ordinarily expect in Crohn's disease. So this is a rip-roaring case of Crohn's disease with considerable inflammatory changes in the right lower quadrant, with these small fluid collections that do not clearly appear to be part and parcel of adjacent bowel, and so I think these could be small abscesses due to a fistulas. I suspect that these fluid collections reflect fistula that often form in association with Crohn's disease and are causing these collections